it a little bit informal so we have some time for questions. So here we go. And I can't advance, let's see. Okay, there we go. So what I like to do today is to talk about sleep a little bit from a biological point of view and how it's regulated by your body, because that partly goes to what some of your issues might be as we age, to look at some misconceptions about sleep, to think about what it means when we don't have good sleep, to think about some of the factors that contribute to sleep and how we might address them. And then if there's time, I'd like to briefly talk about two major sleep disorders that are the two most common sleep disorders in adults, and that is insomnia and sleep apnea. So sleep is an interesting phenomenon because it's something that happens in your brain, but when we measure it, there's multiple characteristics to it. One, obviously, we can't see what's in your brain. Recently we can use electroencephalography. We can look at your brain waves, and we can use MRI and some interesting scanning. In fact, we're doing some of that at Yale. But if we looked at you and we looked at somebody who was asleep, what do they look like? They're not aware of the environment. Now, what's different between that and a person in a coma is that they're arousable if we try. They move less, they're relaxed, usually your breathing slows, and you have less voluntary behavior. In fact, when I was first a nurse, and I bet you Pat at some point worked in a hospital before she became a pediatric nurse practitioner, we used to go around and make rounds at night and to see if everybody was sleeping. How did we know they were sleeping? Well, we knew based on their position and the way they were breathing. And so that sounds like a pretty obvious thing, but that partly goes to how we measure it today. So sleep is multidimensional. As I mentioned, we can measure with multiple things. If you come into our sleep lab, and we have one at the School of Nursing, and there certainly is one at the medical school, we can measure your brain waves. We can measure your behavior. Now, most of you have heard about a lot of these consumer wearable devices like the Fitbit or the Oura Ring or the Apple Watch. Mostly what those do is actually measure how much you move or how much you don't move, because you move less. You do move during sleep, but you move somewhat less. So these kinds of measurements are all kind of looking at different parts of sleep. So this is an example. We use a device called a wrist actigraph, which is sort of similar to the Fitbits that you may have or you see other people have. And if you look at this very busy slide, each line across here from the beginning, from noon, is from noon to noon. And all it's telling us is how much the person moved their wrist. Now, this is an example of some of the data from one of our people who had chronic heart failure. And what you see here is where you see these blue sections. Each one of these is a day. Each line on this screen is a day. What you see in the middle, where it's dark blue, is where the person said, I'm in bed. So that we thought they might be asleep. But look at what's going on with them. They still move during sleep. My guess here, we don't know why. See these little bouts of movement. The bit longer ones, maybe because they got up to go to the bathroom. The little short ones, maybe that they weren't fully awake. But the other thing that's interesting, and why I'm showing you this, and this will come up later, is look at how variable this is. People that have good sleep go to bed around the same time every night, and they get up around the same time every day, regardless day or weekend. In this case, this person had a very variable bedtime, and that would be, in this case, this was part of a clinical trial, and this would be one of the focus of our treatments. So I think it's important to think about, there's many myths idea. Everybody out there now is interested in sleep because of, now it's in the news much more than it used to be. But there's a lot of mythology about sleep. And some of these are all falsehoods here that I have here. And throughout these slides, and I'm happy to share if anybody wants to have them later, I have some web links to some of the additional information. But basically, a lot of people think that as we age, we need less sleep. That's absolutely not true. We need the same amount of sleep as other adults. You can cheat on the amount of sleep you get. You hear a lot of people that say, I can survive on 3 hours of sleep, or I can survive on 5 hours of sleep. In fact, there are a very few people for whom that's genetically true. But for most people who say they can survive on that amount of sleep, if we test them, what we find out is they actually are more impaired than they know. If we bring them, for example, and do experimental work and test their driving ability or test their cognitive function, they are impaired and don't even know it. So this is a really important phenomenon to think about. The other myth is that if you're in the car and you're sleepy, turning on the radio, opening the windows are effective ways to stay awake. That's not true either. Now, I've got a lot of other examples in here besides adults and older adults, because I also want to point out that sleep is a family affair and it's an issue across the lifespan. It's not just older adults that have this issue sleeping. In fact, children, and some of our research now is looking at that. Children and teenagers also have huge issues around sleep. So another myth is that teens who fall asleep in class have bad habits or are lazy. In fact, that's not true. Pat and I work with a very bright nurse practitioner by the name of Allison Moriarty Daly, who works with high schoolers in New Haven, and we are doing some work looking at their sleep. And what they're telling us is they're too busy to sleep, but we know that it affects their school performance and safety and many other things. So the other sleep disturbance is a normal part of aging. That's not true, and I'll show you why in a minute. You see all kinds of jokes about snoring, and people think that's funny. Actually, it's not. Snoring is a sign of sleep apnea. We'll talk a little bit about that. And then the final myth I wanted to mention, and we'll talk about all of these in more detail, is that the best way to fall asleep when you wake in the middle of the night is to count sheep or toss and turn until you fall asleep. In fact, the best thing to do is get up and sit in a quiet place, calm yourself, rest, and then go back to bed, and your sleep will be much better. So just a little bit of background here. This is kind of a complicated slide, but basically I put it here because it's a picture. And if you look at the left side of your screen with those wavy lines, what I'm trying to depict is sleep, from how our sleep changes as we age. So for those of you that have been parents or are grandparents, we know that newborn infants sleep in little batches throughout the day and night. And, it's a sign of infant maturation that when they get a little older, they sleep throughout the night. And they maybe only then, when they're younger, as in 1-year-old, sleep throughout the night, the second line here, and have little bouts of sleep, naps. And this progresses as we get older until we're adults. And most of the time we should be getting 7 to 8 hours of sleep. And generally that's at night. The exception, of course, is if you're a shift worker or something like that. And then there are some differences that happen as we get into our 60s and 70s, and I'll show you a slide in a minute. But the other point is that the part on the right is a little bit more complicated, and this is looking at what's actually happening to your brain waves during sleep. And what the message here, again, if you look at the right side of this very busy slide, is there's really not very much difference in the physiologic characteristics of sleep between adults up to the age 50 and adults older than 50. There's a little bit of decline. This is normal sleep, people that don't have sleep disorders, but it's pretty similar throughout adulthood, including as we get older. I don't know, I'm really having trouble with this idea of old age, and because I'm in your group, but anyway, so going back to this idea of how much sleep we should get, and most of the information I have is on the internet. If you wanted more information or you ever want to print anything out, it's there. This is the National Sleep Foundation on the left. And the question here is, how much sleep do you need? And then on the right side is, how much do you actually get? And so what you see here is across the lifespan. And so this goes from newborns who need from 14 to 17 hours of sleep, all the way up to those of us over the age of 65 who should have still have 7 to 8. Doesn't look very different between middle-aged and older adults. We still need 7 to 8 hours of sleep. So on the right-hand side is what we see. And how do we know that? We know it because there've been done a number of studies in the laboratory and other places where they subjected people to sleep restriction experimentally, and they tested their function, and they looked at what happened when you got less than 7 to 8 hours of sleep. There's other studies where they looked at large populations and asked people, how many hours of sleep do you get at night? And generally, and I've been involved with some of these, like people who got short sleep were more likely to have high blood pressure, more likely to have obesity, more likely to have diabetes, and more likely to have depression and some other mental health issues. By the way, in preparing for this, I saw a slide that said 5 hours of sleep or less is a risk factor for dementia. So increasingly, we're seeing that sleep has protective effects across the lifespan regarding those things that many of us are worried about. On the right-hand side, you see some data. This data are a little bit old, but what the right hand is showing is how much sleep people actually got. So the top here is how much sleep did you get on the weekends? And so if we think you should be getting 7 or 8 hours or more, if you look here, 20% got 8 hours or more, 32% got 7 to 8 hours, and most everybody else got less. So most people, and I don't know how this divided out by age, most people got less than the recommended amount. The other thing that's interesting is on the bottom right corner here, adults who said sleepiness interfered with their daily activities. 72% said no, but that means that almost 30% said yes, that sleepiness, which is a result of poor sleep, affected their daytime function. So this is a big issue. So this part moves a little bit more into your that questions about aging. So this is kind of complicated, but a lot of us think that as we age, that sleep is a normal part of aging. We think it's normal that we might be restless. It's normal, and it is in fact a little bit normal, and it's a little bit normal that we have some people want to go to bed earlier at night and get up, then wake up at 3 or 4 in the morning and can't go back to sleep. That and I'm going to explain why that is in a minute. So there's a part of your brain called your pineal gland, which takes the input, the light input from your eye. If you look at the left-hand side, the light goes into your eye and it goes to your pineal gland, and it affects this thing called the SCN, or the suprachiasmatic nucleus. You don't need to remember the names of this, but the suprachiasmatic nucleus is what prevents the production of melatonin. Now, some of you may know that because you can buy it over the counter, but your body normally makes melatonin. And so at night, the reason you should be in a dark room is because that's when melatonin is at its highest. And if you are exposed to light at the wrong time of day, it has a negative effect on your melatonin rhythm. Now, and so high melatonin is good for sleep. It's good for sleep at night. It normally drops during the day when we get bright light. And so a take-home message from this is getting bright light early in the day is really good for our sleep and helps to set what we call our circadian clock. So as we age, though, the problem is the pineal gland is less efficient at doing this. So what does that mean? So there's two things that contribute to our sleep. One is, and this is really busy, I did pull it out of a scientific talk. There's two things that help us sleep. One is our circadian rhythm, or our normal body clock, that is also partly influenced by things like light. So remember before I said we need to have regular hours, right? Regular input of light, bright light early in the day sets your circadian clock. So your body says, I'm supposed to be awake now. And you're awake all day. And then you go to bed the same time every night. You turn out the night. It's good for your circadian clock. We can also take exogenous melatonin in pills, and we can talk about that in a minute. But normally your body makes its own melatonin. So there's two things that are controlling our sleep. One is that body clock. The other one is what we call the homeostatic drive, and that's just your sleep debt. So if you stay up for a really long time, you build up a sleep debt. It's like being hungry. The longer you don't eat, the hungrier you get. The same thing with sleep. So these two processes work together to contribute to our sleep. And so if you take too many naps during the day, then you're not tired at night. You don't have enough sleep debt to be tired. And so that's why we need to sort of work on both of these things. But the important piece about aging is primarily this, what we call the circadian system. So what happens is we see decreased function of that part of our brain. You don't worry about the names, but this is the issue. It's about light and it's about melatonin. They also contribute to this thing called cortisol, which is a stress hormone. And what happens as we age, as your clock changes, if you look at the top of the right side of the slide where you see 16 to 16. So 16 means 1600 hours or 4 o'clock in the afternoon. So normally, for example, young and middle-aged adults might go to bed at 9 or 10 o'clock and get up at 8 a.m. and that's what you see in the middle. But as we age and our circadian clock declines, what happens is that our phase goes early. It goes delayed. It goes earlier in the day. So you may be sleepy at 8 o'clock at night, but then your body wants to get up at 3 or 4 o'clock in the morning. We have the opposite problem with teenagers. So teenagers, their normal body clock wants them to stay up late and get up late in the morning, which of course is out of sync with school. And that's why and you might have read in the news about changing school start times to match that. So that's primarily what's thought to affect normal sleep and aging, is the change in your circadian rhythm. And there's things you can do about that. The other thing, though, it's not normal to have sleep disorders as we age, but a lot of things that influence are things like pain. If you have arthritis, if you have other comorbid sleep problems, a lot of the medications we take, almost all the medications we take, can influence sleep in some ways. And for those of us that are women, and I look like most of this group is, I'm sorry, I made a spelling error there, menopause, and I'm sure most of you have passed through that phase. That's also a time when we have hormonal changes that contribute to sleep disruption. And for many of us, that goes away. For others, that continues. So there continues to be a decrease in sleep need, but your sleep, many of us want to, and it's not a sleep disorder if you're comfortable with this. If you're tired at 8 o'clock and you go to bed at 8 o'clock and you're getting up at the wee hours of the morning, if that matches your life, that's perfectly fine. That's not considered a sleep disorder. If it's a problem for you and you're not able to do your social activities or interact with people the way you'd like, there are ways that we can help with that. And that would be things like manipulating your light, using melatonin, and we can talk more about that. But the other thing that impairs this is if you take too many naps during the day. So a nap is not bad. A nap can be refreshing, but a nap is the only time it's a problem is if it's affecting your sleep at night. So this is kind of busy, but the point here was that sleep affects all levels of our health. It affects our genetics. It affects us at the basic biological level. It affects our immune system. It affects our cardiovascular system, and it also affects our function. And it goes back, all of those things also affect sleep. So it's sort of like a feedback loop. So sleep loss, as we know, is common in the population. This slide isn't specific to older people, but about 50 to 70 million Americans, or 1 in 5, and these data are a little bit old, and if anything, it's gotten worse in the last couple of years, suffer from some kind of a sleep complaint. That could be they have short sleep. That could be they have very broken up sleep. That could mean they have a disorder called insomnia, which is about 10% in the general population, but as many as 30% of people that we see in primary care settings. Sleep apnea is a large problem, and many people suffer from poor sleep and they don't even know it. And there's some data suggesting that women are more likely to have pain that interferes with sleep and also somewhat more insomnia. So health consequences are many. We sort of talked about them, but a lot of my work is looking at sleep in people with congestive heart failure, and we just completed a randomized controlled trial. And I'm not supposed to tell you until we publish this, but I'm going to tell you anyway. We provided an insomnia treatment, a behavioral treatment for people with heart failure, and not only did we improve their sleep, we improved their fatigue, and we improved their functional level. So, and we didn't do anything to change their medication, their heart failure medication or their heart failure treatment. All we did was give them behavioral treatment, which I'll share with you in a minute. So other consequences are probably pretty obvious, but they also affect not only our decision making, our memory, in young people, academic performance, but also quality of life. The other thing we don't think about often enough is that sleep disorders also contribute to cost to society. So there's a lot of evidence that people that have poor sleep are more likely to miss work. Children, young people have poor school performance. For those of us in the healthcare field, it contributes to medical errors, and certainly motor vehicle and other issues, but also the cost of treating a sleep disorder. So on the left hand, another busy slide here. On the left hand, it's the effect of not getting enough sleep when they polled a large group of people. And what you see here is I'll skip through some of this, but over half people said not getting enough sleep affected their mood. About a half said it affected their family life or home responsibilities. Half said it affected social life or leisure. So this is a big deal. The right side is actually a little bit more troubling even because this is showing motor vehicle crashes by time of day. And before I said that there's many people that don't sleep enough and they don't know they're not getting enough sleep. And what we see is when we trend over time, motor vehicle crashes, what we see over the time of day is that the worst time at the beginning of the slide is midnight. And so you see midnight up to 8 or 10 o'clock in the morning is the highest time for motor vehicle crashes. So when you think about, people, because people are falling asleep behind the wheel. So obviously sleep has huge implications for outcomes, but there's also many inputs to it. And some of the things we do in our everyday lives are going to influence our sleep, things like our leisure work. Increasingly, we're seeing that people now are using, I have the bad habit of reading my iPad or doing the New York Times crossword puzzle on my iPad before I go to bed. The problem with that is that bright light is affecting my circadian clock. Also, the intellectual activity of trying to suss out the New York Times crossword puzzle, especially on a Friday or Saturday, is waking me up. Role demand, some of the work we're doing with young families, mothers, for example, of young children, or people that have to work many shifts. Also primary sleep disorders, which we'll talk about in a minute. But for many of us, as we age, we have comorbid health problems. I mentioned arthritis, heart disease, diabetes, chronic pulmonary disease. All of those sorts of things can contribute to poor sleep. And so if we want to improve our sleep, it's also important to keep these other things well tuned. I'm going to skip this. These are some, I thought this was fun because this was about using your mobile phone or smart, your device, your electronic device. What are the things you did during the last week that kept you up at night? Watching a TV show on TV. So if you have a TV in your bedroom, that could be keeping you up. Playing a game on a computer, etc. I mean, this is actually a little old, but the point is, not only is it stimulating your brain before bed, it's stimulating light, and that light is going into your brain. So many things go on with the inputs. I don't know what your format is. Do you want to have some quick questions before I talk about sleep disorders? Let me know how you want to proceed.
Nancy, that's really up to you. If you'd like to complete the presentation and have questions, then we can do that. Or
okay, I'll finish. I think it'd be easier to do it at the end.
Okay.
But okay, so I did want to talk about the problem of insomnia. As I mentioned, insomnia is very common, and there's some evidence that as we age, we experience more insomnia. Insomnia, though, is different than having short sleep or poorly timed sleep. So many times people who have short sleep, the problem is just that they have too many things interfering with their ability to stay in bed at night, right? I have to work too hard. I have to stay up late. I'm watching a TV show. Insomnia is when you actually do have the time to sleep and you can't sleep during that time. So and this is the official medical or psychiatric diagnosis. These are people that have one or more problems with falling asleep. So normal time to fall asleep is less than 20 minutes. Falling asleep, once you fall, some people fall asleep okay, but once they do, they can't stay asleep. Other people are waking up earlier than they desire. For children, we see this in children as well. It may be what we call bedtime resistance, where they're just hyped up and they can't go to bed. But insomnia is often also accompanied by one or more of these other things: fatigue, memory impairment, sleepiness, behavior problems, or dissatisfaction. And for it to be serious, if it's once in a while, it's not a big deal. But for it to be chronic, we usually think about having it be 3 or more times a week for 3 months for duration or more. And usually this is something that's not better explained by another sleep disorder or comorbid condition. So if your problem is you have arthritis and you're having pain at night, it may not be that you have a problem. You do have a problem with not being able to sleep, but it may be that you need to do some more intervention for the pain, and that may be improve your sleep. Conversely, having poor sleep can make your arthritis and your pain worse. So it's a two-edged sword. So when we help people with insomnia, we think about a number of different influences. One, and this is a very sort of old model, but we think about those things that predispose you to sleep. These are the things at the bottom of the slide, things about your normal self, that you had throughout your life that make you more likely. And I'll show you some examples in a minute. And then there might be some other thing, what you see here, what we call in purple, the precipitating factors. And that means things that triggered it, right? So it may be that someone died and you're grieving. And that happened a while ago, but it affected your sleep, and now you're in bad sleep habits. Maybe you had a hospital experience. Maybe we see people, for example, that have had stress experiences from being in the war or from a motor vehicle crash, and that triggered it, and then you started to have sleep behavior that was a problem, and now you have insomnia. And then and a lot of times the people in our heart failure study can actually trace the beginning of their insomnia to their heart failure diagnosis. But what they're telling us is it's not their shortness of breath, it's not their heart failure symptoms that were keeping them up. They told us, because we asked, that it was some of the same things that keeps other people up: their worries, their fears, their and some bad or inappropriate sleep habits. So, for example, things that once you start with insomnia, what continues it is things that you keep doing, like taking naps when you're having trouble sleeping at night. And I have some more examples. So, what are some examples? Things like personality. There are certain people. So my dad, who passed away at age 93 in January, he was in after World War II, but he was in Korea. He was in the occupation of Japan between World War II and the Korean War. And he lived in New Jersey, and he tells a story about getting on a train and going across the country with all the other soldiers because he had to disembark from San Francisco. And he talks about how, as a young man, all the other men were asleep and he couldn't sleep. To the day my dad died, he didn't sleep well. Now, at the end, he had dementia, and that probably was also affecting his sleep. But throughout his life, he was a very restless sleeper. And so personality, and so we don't know why that is. Could it have been his genetics? Could it have just been something about his personality? But there are people that have that concern. Circadian mechanisms, I described before. It could also be coping. There are people that are very anxious and high strung and aroused. Having insomnia often goes along with things like anxiety. And there's some tendency to think that as we age, we have a little bit more insomnia, but the other point I want to make is it's treatable. You don't have to live with it. There's ways we can help. So when we think about precipitating factors, those are things in the environment. So it could be new onset. I put pills over here. It could be some medications you're taking. I put a picture here of the funeral. It could be that there's some, difficult thing that happened to you that started, you had this stressful experience, and you go to bed and you're tossing and turning and you're upset, and you start to develop sleep habits that aren't conducive to good sleep. And over time, that becomes insomnia. The slide I like the most in this whole talk is the one on the right side. Now, I used to be a nurse that worked in an acute care hospital, and every night, I worked nights because I had little children. And every night I'd have to go around with my flashlight, and I'd had to make sure everybody was asleep. It was the coronary care unit. I also had to make sure they were breathing, but I had to make rounds every hour with my flashlight. So now we have more modern ways of doing that, but I didn't do what this big nurse is doing, and I think I was a little better looking than her. But what she says here is she's making her rounds, just wanted to know if you were still having trouble getting to sleep, and she shines a flashlight. So a really important predictor, a really important determinant of bad sleep is the hospital environment. We've known this for many years. Some of my research addresses this. At Yale New Haven, we have some interesting projects going on where we're actually finding better ways to improve people's sleep, at least in the intensive care unit setting. Some of it's really obvious things like turning out the lights and making it more quiet, and those can be successful. But having a stressful experience like a hospitalization can set you on the path to having insomnia. So other things are conditioning. So there are people that, I can't sleep, I have insomnia, so I'm gonna have a drink before I go to bed because that's gonna help me sleep. Well, there are people that have actually become alcoholics because of that. And then also the thing to recognize is that alcohol actually dries out your brain, right? And so you may be really sleepy when you have that drink or two, but 2 hours later you're wide awake and feeling a little bit hyper. And so that's exactly the wrong thing to do, but it can become a habit. The other thing is, I mentioned use of electronic devices. I'm going to talk a little bit more about sleep hygiene in a bit, but you get conditioned. So you go to bed, you're used to tossing and turning. The first thought you have when you go to bed is, oh my gosh, I'm not going to sleep tonight. I'm just going to toss and turn. And guess what? If that's in your mind, that's exactly what you're going to do. You're going to toss and turn. So we need to work on our behavior, but also our thoughts. So this is a treatment that we have been doing. We just did it as a research because it hadn't been done in people with heart failure. But this is a treatment that you can obtain, and you can also do some self-management of this. Before you go that route, it's available online. There's now apps and there's ways to help yourself to do it. But this is called cognitive behavioral therapy for insomnia, and this is a behavioral treatment. And what this does is helps to address those things that I just talked about. It focuses on your sleep behaviors. It focuses on your thinking about your sleep. And the effects, it's been widely studied over the last 20 or so years. And the effects of this are actually better than sleeping medication. And it doesn't have the same side effects as some of those drugs. The other advantage to it is if you stop the drugs, if you're on sleeping medicine and you stop the drug, your insomnia may come back. What we've observed, and we found it in some of our research, is that what people did was they learned skills that improved. And once they continued the skills, so in our study, we recruited people that had problems with their sleep and we gave them an 8-week treatment. And a year later, their insomnia was still better than the control group. They had a little bit, but it didn't really come back. So people find this very satisfying and very helpful. So this can be done either, we did it in a group format because we thought the people that we were working with would like the social interaction. Of course, we had to turn it into telehealth with COVID, but a lot of things went to telehealth. It can be done with an individual therapist. It can also increasingly be done telehealth. And there's also ways that you can get an online program and go through it yourself with or without a therapist. Now, some people are going to benefit from more, some people are going to benefit from less. We do offer that here in the Yale Sleep Medicine program, and there is a psychologist who does this. Traditionally, this was done by a psychologist who specialized in sleep medicine. The problem is that there are very few of those people out there. And if we want more people to get it, we need to train more people to do it. So in my work, one of the nurses in our school, her name is Joanna Ineko, gave the treatment to the patients. And so increasingly we're seeing nurses that are trained to do this. So what does it include? So it includes basically these things, and I'm going to briefly go through them. But these are things you could do for yourself anyway. I mean, it's good to, if you really have chronic insomnia, but if you just have a little bit of insomnia, you might want to try these anyway. Having a regular sleep time so that even on the weekends, you want to go to bed during the weekend. Now, if you're retired, I suppose your schedule's a little bit different. I haven't figured out what my retirement's going to look like soon, but try to keep the same schedule every day regardless. No naps. Now, none of this is a problem if you're not having an issue with sleep. You should have regular sleep anyway. But if you enjoy a nap, take your nap. The issue is only if you're not sleeping well at night. Relax. Do something relaxing and enjoyable pre-bedtime. Make it a ritual. Things like, some people I have a hot tub in my backyard. My husband and I go in the hot tub before bed. Some people like to listen to relaxing music. Some people like to read a relaxing book. Don't read something that's scary or stimulating or going to wake you up, but something calming. Lavender, massage, whatever works for you. There's been some interesting studies actually about the use of quiet, calming music to help. What you're trying to do is wind down your brain. Avoid thinking about the troubles of the day. The other thing is a little bit more direct. don't go to bed either on a full stomach or hungry. You don't want that pepperoni pizza an hour before you go to bed, but you also don't want to be hungry. A little piece of cheese and cracker, a little milk, really can be helpful. You want to avoid, you do want to get adequate exercise, but you want to exercise early in the day, preferably with bright light, as I mentioned before. Yeah, and you want to, it's okay to drink alcohol, but not within around 4 hours of bedtime. Unless you have a health reason why you shouldn't be doing it. Avoid caffeine. For some people, caffeine sticks around a really long time. So if you're one of those people, stop the caffeine by noontime. Have your morning coffee and then don't have any more. I'm a big fan of Diet Coke. And if I have my Diet Coke at 4 o'clock in the afternoon instead of 1 o'clock in the afternoon, I can't sleep. And I should know better. So yeah, experiment with that. The other thing to know, though, is that a lot of the decaffeinated beverages that we have access to, some of them have less caffeine than the regular product, but many of them have some caffeine. And so if you're having a problem, you might want to get rid of those as well. Have a sleep ritual. Now, we did this. I have children and I have 4 grandchildren, and we always had a sleep ritual with them. Take a bath, put on your pajamas. We'd read a couple of books. When my son, who's now 38, was growing up, he had played this game. He didn't want to go to bed. We read 1 book, and it had to be 2 books. It had to be 3 books. We had to control it, but there was a ritual. And have some kind of a ritual. Are you going to have a little snack? Are you going to take a warm shower, put on your pet jammies, do the same thing every night, because what that's doing is telling your body it's time to get sleepy. It's time to go to bed. Go to bed only when you're sleepy. And if you're in bed and you're tossing and turning, I said before, get out of bed and go in another room and do something quiet with the lights low. This sounds obvious, but thinking about a dark room, reducing noise. If you haven't live in a noisy place, you could use earplugs. You can use an eye mask if your room is too bright. Put room darkening shades if your room is in a place where there's a street light coming in the house. The other thing, and people laugh when you say this, is the other problem with insomnia is what happens is you attribute the bed to not being able to sleep when you're in there tossing and turning. And so and nowadays with the pandemic, with everybody working home, a lot of people have been doing, reading in the bed, watching TV in the bed, doing their work in the bed. What that does is it tells your brain that the bed is not a place to sleep. And so what we do is we advise people to use the bed for only 2 things, sleep and sex. Anything else, you want to get out of get in a chair, get in a sofa, or go in another room. So I mentioned the relaxation, whatever works for you. This is a little bit tricky, so I'm going to skip it, and you probably wouldn't do it for yourself, but it is part of the CBT treatment, where what happens with people with insomnia is they lay in bed for a long time, but their sleep is not efficient. In other words, they're laying awake for a long period of time. And what this treatment does is it has you, with the therapist, you cut back the time in bed. So if you're laying in bed, if your normal time is 8 hours in bed, but you're only sleeping for 7, we may cut you back to say only stay in bed for 6.5, and gradually, as your sleep improves, you're going to fill up that whole time with sleep. And so that's a technique. And you have to do that carefully because it can make you sleepy during the day. But that is a part of this treatment. So the other important thing, and this is, where the psychology comes in, is people get these ideas about sleep. So things like, oh my gosh, if I don't sleep tonight, I'm going to have a motor vehicle crash tomorrow. Oh my gosh, if I don't sleep, I'm going to die. Oh my gosh. So, and they feel like they've lost control. So they have unrealistic expectations, and so you go to bed and you say, oh my gosh, I'm not going to sleep tonight. So as I said, then you get in bed and you toss and turn, and all you're thinking about is the problems of the day. You're thinking about, oh, I can't sleep, and you're getting worse and worse and worse. And so what this treatment does is works with people and helps them think about how they're thinking about sleep. One of my mentors many years ago was a nurse and a psychologist who was a sleep specialist. And she used to teach her patients to keep a little journal by the bedside. And so, because a lot of what happens is people go to bed at night and their brain turns on and they're worried about what do they have to do tomorrow. They're worried about their kids. They're worried about whatever, worried about their health, whatever they worry about. She says, keep a little journal by your bed. And when you have those thoughts, write them in the journal. And by writing them in the journal psychologically, then they're in the journal and not in your brain. So if that works for you, I mean, it's important to try if that's an issue for you. Okay, so I did want to make a comment about this idea of consumer wearables. You know, you see everybody wearing their Apple Watch and their Fitbit. I don't want to get into trade names. And I'm at Yale, and all these people are coming up to me and saying, look, at my watch is telling me I slept this much last night, or I have this much REM sleep. Well, so there's been a huge growth in these devices. And the problem with these devices from both a clinical and a research point of view is if you had 10 different devices, they're all telling us something different. And so they may be useful to you engaging your own progress from night to night, but it's really important not to just rely on them. The technology is improving and soon they will be wonderful. But right now, they're not approved for clinical use. If you came into this, I don't right now work in a sleep clinic, but if you came into the sleep clinic and you said, oh, it says I had this much REM sleep, or I would say, really? Because we don't really know that. So I think that's important to take all those things with a grain of salt. So I'm going to skip this for time. I got a little ambitious here, but I did, and I'm imagining some of you, if you have insomnia, you might be on some of these medications. There's been a large growth in drug treatments, hypnotic medications for insomnia over the last few years. Some of them are drugs that were specifically designed to be for sleep. Others are other kinds of drugs that make you sleepy, things like anticonvulsants, things like some antidepressant, like trazodone is an antidepressant often given to older people, but it makes you sleepy. And sometimes a physician or nurse practitioner will put you on that at a low dose to help you with your sleep. So there's a plethora of these drugs. The one thing I really did want to point out, though, is there's also a lot of over-the-counter medications. And what a lot of those drugs take are like diphenhydramine. That's like in Tylenol PM, for example, not to pick on Tylenol. But diphenhydramine is a drug that dries out your membranes. It has really bad interactions with some other prescribed medications. And the older people that we've worked with have told us that when they've taken it, they felt it hangs over into the next day. And they felt very sort of, dull and confused or sleepy. So it's really important not to do this. And when I was visiting my dad a couple of years ago, when he was still living in his home, he was, going to the drugstore and he was buying all these different things, but some of them were multiple different pills with the same ingredients. And so it was almost like getting an overdose. And so you really have to be careful. And if you take those, they're not necessarily bad, but if you're going to take them, talk to your healthcare provider. There are a number of other things on the market, like melatonin. Melatonin is helpful to some people. What's important to know is that melatonin is not regulated. It's regulated as a supplement. It's not considered a drug. And so each of the preparations that you might see might be a little bit different, and they might have slightly different effects. We see a lot of talk about herbal remedies, things like valerian and others. Those are all very interesting, but there's very little research to support their usefulness. So these are important alternatives. I don't want to say that hypnotic drugs don't help people. Some of the older ones, by the way, were addicting, and that was an issue. But I don't want to say that they're bad to use, but most people in the insomnia field believe that you start with the drug, and then if you continue to have problems more than short term, try the cognitive behavioral therapy, and then you can taper off the drugs. In fact, part of the treatment that we do is to help people to taper off as their sleep improves with the behavior. So I did want to briefly talk about sleep apnea, and then I'm going to stop because I wanted you to have some questions. Sleep apnea is very common in the population. Some people think it's common in about 24% or 30% of men. In women, it's less common until menopause, and then the rate increases. And this is a condition where we have snoring, which can be loud or noisy, some people will choke or gasp during sleep, and that's because you stop breathing. Oftentimes, but not always, these folks have fatigue or sleepiness during the day. It's often associated with obesity, and there's increasing interest in the role of sleep apnea relative to our cardiac and diabetes problems, and thinking that if we treat it, we might improve some of those outcomes. What I have on the right here shows what this actually looks like in your breathing if we plotted it. And so what you can see at the top here is that not only you see this nice up and down as you're breathing. What happens is the airflow is blocked because of the structures of your nose and your throat, and then also your body has to work harder, and so you get more chest effort, and that's where the gagging and that gasping comes from. You stop breathing, and then your body has to compensate and take a really deep breath. And so this is not only is bad for your oxygen, but it's bad for your sleep. It makes you wake up a lot. So this is pretty busy, so I'm going to skip it, but these are the biological effects. Your airway collapses. You have to work harder to breathe. You wake up a lot and you have low oxygen. On a small screen, this doesn't work very well, but the right-hand side is a figure that shows what are some of the outcomes. Things like heart problems, I mentioned, even problems with your liver, breathing, etc. It's also a major cause of motor vehicle accidents, and you've read about some of the train crashes and other things that have happened. And when they traced it back, they found out that the train operator had this problem. So how do we treat it? Well, we treat it with weight loss. Has shown some effects, but that's hard for people to do. Some people have sleep apnea only when they lay on their back. So an old-fashioned treatment for that is to put a tennis ball in the back of your pajamas. Now you can buy a shirt that actually has something like that in it. You can get a dental appliance that you wear, like a mouth guard at night. And then there are surgical procedures. But the most effective procedure is what we call continuous positive airway pressure, where you have a little box next to your bed that delivers air to your nose through a mouth or through, and there's multiple, gave you examples here, there's multiple different kind of masks to apply it. And so there's increasing interest in the sleep community, including some of our research at Yale. I'm involved in a study we've been looking at if we treat sleep apnea early in stroke survivors, will they improve their function more than if we don't? The problem with sleep apnea treatment in general is a lot of people don't want to use the mask, but for those who do, they find very good effects. So that's sort of where we are with that. So I'm going to stop here. I don't know if you have a way to share the slides with each other or to print them or email them. I certainly would be willing to do this. Some of the information that I shared in the slides are these links here. There's a lot of very useful, and most of these are geared to the public and consumers, so it's not real technical. Some very interesting material. And if any of you are involved with organizations, there's actually that you want to share things with, you can actually print out some of these. There's flyers and things on these websites. Anyway, questions?
Thank you, Nancy. That's fantastic, but an awful lot to comprehend.
Yeah, you got the whole world of sleep medicine in an hour, so or almost.
And I would like to ask you if you could share the slides with Home Haven, so that
Sure.
for those who are unable to attend today, or for me, for taking notes to write up a short summary for our newsletter, that would be very helpful.
Of course, I'll email them to you. Is that okay?
That's fine, Nancy. That's great.
Okay.
Okay, are there questions? And if we can share your screen now with the view of standard where we see each other. Let's see.
So we would need Nancy to stop sharing her screen.
Oh, okay, that's true.
That will do it.
Okay, I did.
Very good.
Did
Thank
that help?
you.
Okay.
All right, good. All right, questions. Questions from all of us.
We got them.
Okay, so my question is if I keep waking up because I'm in pain, I should go to my doctor and get pain medication so I sleep through the night?
Well, it could be pain medication. I don't know what the cause of your pain is, but it could be that there's other things, I don't, some people, it could be heat or ice or relaxers, but yes, pain can keep you up all night. On the other hand, when you don't sleep well, it can make your pain worse, depending on, the reason for the pain. So yeah, whatever, so there's a lot of interest in, non-pharmacologic. Again, I don't want to get into what kind of pain you have. It's sort of beyond this, but there's a lot of interest in non-pharmacal ways. Some of the things that actually improve our sleep, like relaxation, right? Like music, like distraction, taking a hot bath, depending on the kind of your pain, sometimes that actually will help your pain as well as your sleep. So again, details of that is sort of beyond this, but that's what I would suggest.
Others?
So I'm an erratic sleeper and a good napper. I can lay down in the middle of the afternoon if I'm feeling drowsy and too much Zooming or whatever. I can lay down on the floor for about 14 minutes, and in 2 minutes I'm asleep. And in 15 minutes, I'm rested and ready to go for the rest of the day.
And does it bother you? Does it affect in your sleep at night? I mean, do you feel bad? I mean, do you feel tired during the day, aside from before you take that nap? You have energy?
Yeah, well, I certainly do after.
So
And
there's nothing wrong with taking a short nap. It's
Yeah.
when your nap is interfering with what's going on at night.
And I'm also erratic in terms of when I go to sleep or when I wake up. But again, I feel rested and okay. So sometimes I go to sleep at, I don't know, 9 o'clock or 11 o'clock. This morning I got up at 6 o'clock. Sometimes I get up at 8 o'clock and 7 o'clock. But again, I feel rested and good and healthy with my variety. I guess I'm saying.
Right. If it doesn't bother you and you feel like you're able to do what you need to do and what you want to do, it's not a problem. I mean, and then the other question is, well, why is that? Is it because of your social activities or what you're doing or whatever, and that's a personal decision.
Yeah.
I guess the point be, if you had insomnia, if you had concerns about your sleep, if you didn't feel good during the day because of your sleep,
Yeah.
that's when, it's good for everybody to have regular sleep, but there's also life. You have to live your life too. So if it doesn't bother you,
Yeah.
and so, but if you wanted to change it, you could get into different habits,
I like being irregular. Whatever.
you made it this far. Yeah.
I'm glad that you talked a bit about diphenhydramine, Benadryl, or the other over-the-counter sleep aids. Occasionally I use them, but they do almost seem to be like Dumbo's feather. I tossed and turned last night, so maybe I ought to take that one little 25 milligram pink pill, and I know I will sleep better tonight.
Try some melatonin instead, Pat.
I tried that, and I didn't seem to have much effect. I should probably try it again, but I think I need to go back to your cognitive behavioral therapy. But this is going to have to change my entire bedtime routine.
Right.
I mean, that's when I read books and novels and stuff. And so what do I?
So don't read the scary, I don't know what you read, but you don't read the scary one. You
What's
read
the
the
story?
quick one.
What's going to happen in the next chapter?
I know I shouldn't be having this talk. I keep my iPad under my pillow, and my husband's a sound sleeper and I'm pulling it out all night long. So,
but that's not good for the light, right?
No, it's really bad. And you can get blue blocking. By the way, I forgot to mention, they have what they call blue blocking glasses, or I think there's a cover you can put on your iPad that blocks the spectrum of the light that's bad for you.
Oh, because your idea, occasionally I have tried, if I'm tossing and turning, to get up and then I'll go downstairs. But what I want to do is either go on the computer to get a head start on the next day's activities or read the book. Therefore, I need a light. I don't see myself sitting in the dark.
Well, you don't have to sit completely in the dark, but you don't want to make it real bright, low light.
Low
But
light.
the problem is, if you can't read with low light, that doesn't help, right? Yeah, I know.
So when I come up to bed later on, the Pat's book is on her chest The glasses are on her. She's sound asleep. I turn the light off. I take the glasses off, put the book next to the bed. It works for both of us. Kind of.
Teamwork. Teamwork.
Nan,
Man.
Turn your sound on, Nan. You're muted. There you
Thank
go.
you. Thank you. My son gave me glasses that supposedly take care, is it the LED in the computer?
Yes.
I'm sorry, I'm really dumb about all this stuff.
That's, I think,
Yes.
what they call what I mentioned before, that block. So there's different spectrums of light, right? And it's the blue light. It's what you want is to block a certain spectrum of light. And it sounds like that's what those are.
And are those, is this a good thing to do?
Yes, it is a good thing to do, but it doesn't block all light. It's not like the same as being dark, but it does block the spectrum of light that's really the problem for your biological clock.
Okay, thank you.
that sounds like it might be something that would benefit a lot of people.
Yep.
Are these, I've never heard of these things. These are glasses which,
It's blue blocking. I think there's glasses, but I think they also do some kind of a cover that you can put on your device. I don't have any of those, but
Yeah, but those are very hard to find. We try to find what's called a film because I have a brand new computer, and to find the film is
Right.
very difficult. Some, I don't know why, but they don't make it, or it's not, I don't know. It's not very easily available. The glasses are available.
and would
I
you
mean,
wear
you
these
can get
every
them on
day?
Amazon, you can get of various prices, you can get them from your optometrist.
Wow.
They're,
Ronan has two pairs he wears when he does his remote learning. It's just blocks the filters out.
right,
30 years ago, you used to be able to get a little plastic thing that went over your computer screen that blocked the glare. It's the same principle as blocking
yeah.
just that particular light from to prevent eye strain.
Oh.
And it's gotten really popular because of all the zooming and the kids
Right.
on remote learning.
Wow, never knew.
Other questions? Nancy, if, I'm sorry, who
Go ahead.
spoke?
sorry.
If we think that we may have a sleep disturbance and we've taken some of these ideas and that doesn't seem to work, how do we proceed from there? We discuss this with our primary healthcare provider. Is there some type of referral we should be looking for? How would you?
So yeah, so the problem we have, is that, if you go to your routine primary care doctor, your internist, your family, whatever, dermatologist, actually gerontology people are usually better at sleep than others because so many older people have the problem. But so you get, you go and you get 15 or 20 minutes and they don't have time in your routine visit to ask you all these questions. They just don't. And the part of the problem is that some providers are not, I'm trained in sleep, right? They have all these other things they have to do and they're not always that comfortable even asking about sleep. Some are better than others. I don't mean to be critical. It's just a lot of things for them to cover. By the way, Pat, I think pediatric providers are much better at this, at least the developmental
As the
part.
parents complain.
Yeah. So yes, mention it and then push it. So when the patients, we did some interviews with our heart failure patients before we started our clinical trial. So I wanted to know what they thought. And then they told us, well, they were going to a cardiologist or internist. And, I go to my doctor. He never asked me about sleep. When I do, he doesn't want to. So you have to push it. You have to say, this is really upsetting to me. You have to put, and some are more open than others, but some of them is just not on their radar screen. Their comment, and we wrote this as a quote in a paper, the doctor takes my blood pressure, he gives me a pill and he sends me on my way. It doesn't ask me about these behavioral things. Now, I'm not here to criticize doctors, but they don't have time either, and they're not all well trained to do this. So you need to bring it up, and then you can get referred. There's sleep. So Yale has a presence for sleep treatment. UConn has a presence up in Farmington. Yale has a presence at the sleep program is Yale University doctors, but it's in North Haven, and I think up to in I think it's Guilford. And so yes, you can get a referral. If your problem is sleep disorder breathing, they're going to do if you have sleep apnea. And so to get to the point of figuring out what's wrong, they might have to screen for something. So some people, they think their problem is insomnia, but their problem is they're waking up a lot because they have sleep apnea and they don't know it. So if you go to the sleep program, a specialist, they're going to screen for all different kinds of things. So you have to sort of know that. And it depends on your insurance, whether you can go directly or whether you need a referral. I don't know what goes on with Medicare or what, depending on your plan, maybe.
Yeah, my concern is that, as you say, because this is not the specialty that everybody has, and there's so many other
Right.
things they have to worry about, is the quick fix is a medication. And then
That's true.
And
Right,
that
because-
goes into polypharmacy, and we're all trying, as we get older, not to have to take too many medications and the interactions with them. So
Right, so you have to sort of be assertive, and it's okay to take a sleeping pill for a couple of weeks. It's not good to take it, if you're in a stressful situation or whatever, but it's not good to take it for many weeks or months at a time. Some of the newer ones, they're actually marketing that you're going to take this forever, and they're actually very expensive. So, I mean, I was doing some consulting with a drug company, and I stopped because I didn't believe in that.
Yeah.
So, drugs are not necessarily bad. You just don't want to be on them forever, and you don't want to be on things that are going to interfere with all the other things you need to take.
yeah, and then why is the question? Why are you having that sleep problem?
Right, and that is true. That healthcare providers, that is the easiest thing for them to do, is to write a prescription.
Yeah.
So you need to sort of advocate for yourself, and if you think that it's not being asked for a referral to the sleep program.
Okay.
There's many others. I just happen to work with Yale.
Yeah.
I joined your heart sleep study, and I went through the whole program. I found it, on the one hand, I realized I don't really have a sleep problem, because I heard the problems that everybody else had. And what I had started to do, well, there are two issues that I wanted to talk to you about.
Okay.
One is the use of a routine, and part of my routine is that I take 2 milligrams of melatonin just when I'm ready to go to sleep. When I realize that I forgot to take the 2 milligrams, I wake myself up and I take them. And I found it very, very successful. I think it's probably in my head. So that one question I have for you is, can you recommend a reliable source of melatonin so that I know that I'm taking something that doesn't have additives that I would not want? I'm using it as a crutch. I don't believe, on the one hand, that I'm really falling asleep because of the melatonin, but I do believe it strongly enough that I take it. So that
Call that a placebo effect. Yeah.
Exactly. I'm very receptive to a placebo effect. I
I'm
believe
sorry.
in it.
That's interesting that you were in our trial. I'm sorry. I really don't know enough about the different preparations to be able to answer that question. But of all the things you could take, that is the safest, compared to taking Benadryl or something else. And there's not a lot of hard data on this, but there's actually some evidence that melatonin is actually good for your heart. So if you were in our heart sleep study, that's probably a good thing that you're taking melatonin.
And the other thing is that I took part in the study for when I have heart failure, and hypertrophic cardiomyopathy. And so that I really know that my heart is going to continue to degenerate, and that I just have to take advantage of whatever I can. The other thing is that I wanted to be able to try out cognitive behavioral therapy, and I was hoping that I was going to be put into that part of
Oh,
the
you got in
study.
the control group? Oh, you were in
I
the
was in a control group.
Oh, so sorry. That's with research. Yeah.
It was
Okay.
probably just as successful as if I were taking the cognitive behavioral
So,
therapy,
so
because
I will tell you, we didn't publish the paper yet, so you have to promise
No.
not to, cone of silence, don't tell anybody. Where were you on it recently? Because we did a little pilot study a few years ago. Were you in it this last couple of years?
I just finished it
Okay, so you just
last couple of years, yeah.
So what was
I mean, I
interesting?
withdrew from the post study because I said, this is disturbing my sleep.
Yeah, all those questionnaires we made you do. So, so there's two groups. One, the control group that we had was
Yeah,
was things that heart failure patients should learn about anyway, right? How do you manage your diet? How do you manage not eating too much sodium or getting enough exercise and things like that? And we figured that what we had was pretty strong, and that in fact it would be, just as good as the insomnia treatment. So we were a little worried. And in fact, when we did the analysis, both groups improved in their sleep and their fatigue, but the insomnia treatment group improved a little bit more. But the other group did see benefits, so that was good too. Interesting, small world.
And how can I find out more about cognitive behavioral therapy? I don't think that I don't want to pay for it. I don't know if it's necessary to have Medicare pay for it. I want to know more about it because I think that it is probably a helpful therapy, a helpful system for me to know about when I have real problems. To be able to control.
So I mean, to get, I'm not a clinician. I don't actually provide it except through the research, so I can't do it. But there are, what is his name? There's a psychologist. You'd have to pay though. His name is John Klein, and he's in the Hamden area, Kline. He worked with us on our study, the Yale Sleep program. I'm guessing your insurance would pay if you have Medicare. I don't know. There are books you can read about it that give you a little more information than what I gave. You can go on the internet and get more and enroll that way if you have access to the internet. I mean, that's the limiting factor. So
Yeah,
yes, you
Emily,
can access it.
I would try going online to see if you can find some programs that you can work through yourself to see if they would be beneficial. That might be, since you've already expressed interest and you understand the concept behind it, that might be sufficient enough. Or if you try it and it doesn't work, then you can turn to try to get more assistance.
If I can find a way to get it to you, I will send you the materials that we gave. I can at least send you the booklets and the things we use for the treatment group in our study. Would that be helpful?
I'd love that. I mean,
Okay.
because I think that it's very useful to take part in studies if you're not taking any medication.
I get it. Yep. Pat, can I forward that to you? Would you?
Yes, you can forward that to me, and I will make sure that Emily gets it.
Yeah,
Thank you. And if you
thank you for being in our study.
Or Joanne and Echo may know of a particularly good link that would be helpful for those who are interested in cognitive.
Yeah, I can look. I will look too, and I'll forward that to you, Pat. Anyway, thank you, Emily, for being in our study. That was great.
I knew your name was familiar. It's just on the front page of my book.
And I don't know the names intentionally. I'm not supposed to know everybody that's in the study. So
yeah,
of course not. I'm anonymous.
Yeah. You know, Nancy, one of the things that we have tried to do with Home Haven, because we are a group of active, involved people, is we have tried to identify studies at Yale that are looking for older adults to participate, because we learn from it. and you learn from us to help the larger community of older adults. So, you know, if you come across other studies on sleep or other issues that people are looking for older adults to participate in, let me
got it.
know, and I can go through the health committee and if we
So
think.
the YCCI posts all the studies. Did you know that? There is a website that lists the Yale studies.
Actually, I look at that and I enrolled in another study now because I have close friends who have neurodegenerative serious diseases, not particularly brain diseases, but neurodegenerative to the point of their life being destroyed. It's more than one person. And I'm participating in a study, but I look at the way the study is working and I think, oh, they're not going to find out anything from this. However,
Nancy, if you send me the link, I will
Yep.
run it by the health committee and maybe we can, but we don't want to send everybody, you know, 300 links, but if we can identify some, yeah, that look like they might be of interest to our membership, that would be great.
yeah.
So if you are in the Yale system and if you have my chart for your chart electronic, there is a way, and I kind of don't ever bother to do because I don't have time, but there is a way that if you have certain conditions, they will send, that's how we got some of the people with heart failure for our study.
Yeah,
They will
that's, I
send
was,
you an email and say, if you're interested, respond to this, but I think you can go in and search it too. So if you have some facility, that would be worth looking at.
Yeah, okay, well, it'd be good information to share with our community.
Great.
Well,
Bye.
oh, okay, Cecile.
She's saying goodbye.
Oh, you're saying goodbye? Okay.
Oh, I'm fine. I have time. I just did it, but Cecile was saying goodbye. Okay. Okay.
Thank you,
Well, it
Nancy.
was nice. Yeah, hi.
Thank you.
Oh,
Yeah,
you're
this-
welcome.
This was great. I'm glad we, one of our team members suggested the topic and then I said, I know to talk about it. So I
Right.
really appreciate you spending the time with us today. And we may have other questions and I have your address, so I'll
can
share that
remind
with
me.
you.
Great. Thank you. Thanks,
Okay,
everybody. Nice
thank
to
you,
meet you.
Nancy.
Thank you very
Have a
Bye.
good weekend.
Thank
Bye.
you. Thank you very much.
Bye-bye.
Bye, everyone. Take care.
Yes.